but you are from Italy, so you may understand.
I'm still Italian. I'm in Switzerland, but I'm still Italian, also on the time, don't worry.
Okay, good. Okay. How is the weather now in it's already cold?
It's not so cold. It was not a cold cold autumn like last year, but now it's starting a little. I mean, starting maximum 3 degrees up to the zero. That for you is already very cold, but for Switzerland is not. I mean, this time of the year we are used to be around zero. I mean, difficult is going more than zero. But today we have a little bit of sun, because usually we are always in the fog. I mean, I live for almost 7 years in Parma. I never see so much fog like in Bern so far. But today is a little bit a nice day, I would say.
Good. Here is already hot, as usual. But it's better. I couldn't stand this cold weather there. So how long will you estimate your lecture?
To be honest, I think 1 hour and something.
Okay.
Trying to explain everything. I try to be as simple as I can.
Sure.
I think that we can wait just more 5 minutes, and after that we can start.
Probably not even 5 minutes. Let's give a little bit more. We already have 5 minutes, and Dr. Paulo is here with us. Good morning, Paulo.
Good morning.
We are already in the streaming, okay? We are already transmitting in YouTube, okay? Do you still have your Brazilian t-shirt, Ludovica?
Not here. And
but you should use today.
It's a huge mistake, because tonight I'm going to see Brazil playing at Brazilian place. So it's a huge mistake not having it here.
Exactly. Yeah.
But on Monday evening, it was a huge match, huh? Brazil against Switzerland.
Yeah. I would call you at that time, but I said, no, she's just Italian.
No, it was, okay. I mean, I'm not standing as an Italian. I was not standing for Switzerland. I was not standing for Brazil. I was just thinking why we are not there.
So at this time, we cannot fight.
No.
Well, we still have the Argentinians to fight.
Let's see. It's a good team. I see a good team.
Yeah. Well, actually, I'm not a person into football or soccer or this.
As a Brazilian.
Yeah. Shame on me. Okay, Paul, but don't worry. Okay, we understand. We got it. Okay, more 2 minutes, and then we go, okay? I can see. I can see your dog. Well, it's not yours, right? So you cannot control it. But thank you for coming, okay? Thank you for being here with us. And that at the end, if your dog allows, I wait for your questions, okay?
I think that we can explain for people that are watching from YouTube that they can send questions on the chat over there, and we're gonna bring these questions for here.
And also for the people that are watching and here with us, we are gonna put at the end of the presentation a form for you to complete to have the certificate of the lecture, okay? So not you, Ludovica, we send you your certificate later on. But for the people that are seeing us, please be careful and pay attention at the end of the presentation that we are gonna put the form for you to put your name, your email, your institution, and for us to send you a certificate, okay? And also, as Pedro said before, also the questions you can send through the YouTube, and Pedro will bring for us at the end, okay? So I believe we can go ahead and start. So it's my pleasure to introduce Ludovica Parisi, that is here with us. Thank you for accepting, Ludovica, to be here with us in this presentation. And well, Ludovica is a bachelor in biomolecular science and technology from University of Central. Then she had her master in medical, veterinary, and pharmaceutical biotechnologies already in University of Parma. Then she had her PhD in molecular medicine, also in University of Parma. And during her PhD, Ludovica was here with us as a visiting student for a time that she was collaborating with us in some research. And also she was in the United States with me in University of Pennsylvania as a visiting student while my time there as a visiting scholar. And after that, Ludovica finished her PhD and she got a osteology, she was an osteology research scholar in University of Berna, where she is now. And now she figures as a postdoctoral research fellow in University of Berna. And I have to say that all this collaboration with Ludovica, and I have to attest this here, it's because of our collaboration with Dr. Guido Macaluso, which is also Benedetta that's here with us, mentor, and who was the one that was responsible for all this great collaboration we have with University of Parma. So years ago, we began this collaboration in research, and as I always say, research brings excellence in everything else. So through this collaboration, we've done not only in research but also in academics. We conduct an agreement here between our two universities, the University of São Paulo and University of Parma, and we have like a more than 6-year agreement in mobility, in student mobility, and now we have a double degree between our institutions. And this is a great, great pleasure for me to say here. I have to acknowledge and to thank Dr. Guido for all these possibilities we are having. So please, Ludovica and Benedetta, extend all the things, all my words to Dr. Guido. He could be here with us. He couldn't be here with us. Probably he can be later. Let's see. But please send my words to him. Okay. So Ludovica topic of today is gonna be the use of autologous lip-derived fibroblasts for the reconstruction of congenital bone cleft in cleft, lip, and palate-affected individuals. So Ludovica, please, the stage is yours. With no further ado, take the stage. Okay? Yeah. I'll close my mic and camera, and you please take your place.
Yeah. So first of all, thank you, Professor Daniela, for the introduction. It was really a nice introduction. I'm really happy to be here and to give this kind of lecture for your student. It's been a long time since I came to Brazil, and as we were saying, in this 7 years, a lot of things has happened. And I think that, I mean, very great thing happen if we are still here after 7 years. I mean, giving lecture each other and still collaborating together. So welcome also from my side to everyone. And I would like today to give you this lecture about the topic of the research that I'm following here in Bern. So that is about the use of the autologous lip-derived fibroblasts for the tissue regeneration in cleft, lip, and palate patients. So before I start, I would like to give you all a brief introduction on myself. So first of all, I'm Italian. I was born on a small village on Lake Garda that is in the north of Italy. And this is still the village where I come back every time that I need to go back to Italy and to escape from Switzerland. And my family is still living there. And when I was 19, I started my Bachelor of Science in the University of Trento. Trento is a small town that is close to my hometown. And I did my Bachelor of Science in Biotechnology. And when I was there, I was already passionate and interested in tissue regeneration. So I did my work of the thesis in tissue regeneration. And this is also the reason for why after my bachelor, I decided to move to Parma to do my master in medical, veterinarian, and pharmaceutical biotechnology, with a special focus also there in tissue regeneration. And Parma, I mean, is a city that I have to admit I fall in love with, and I decided to stop after my master for doing also my PhD there. And my PhD I started in 2015, the same year that I came for the first time to Ribeirão to visit and to start a collaboration with Professor Daniela. And also with Professor Daniela, I moved couple of years after for 3 months to the US, to Philadelphia, where Professor Daniela was visiting professor there, and we also spent other 3 months together in the US. And then at the end of my PhD, I decided that I wanted to go abroad to have some further experience out of Italy. And I was really, I'm really grateful that I could get the opportunity with the Osteology Foundation to get the osteology scholarship. And I came for the first time to Bern. So I spent my first year here as an osteology scholar. And after that, I stayed and I started to work in the lab where I am now as a postdoc researcher. So this is a little bit my background. And so I would like also to introduce you the place where I am, because this is also important for you in order that you can understand a little bit what we do. So we belong to the School of Dental Medicine in Bern, that is this building that I highlighted in yellow. So the School of Dental Medicine in Bern, I mean, is a huge institute, and I'm always happy and proud to say that we are in the top 10 dental school all over the world. And this year we have been granted with a 7th place. And I think this is also due to the internationality of the place where we are, but also to the good quality of the research that we do. I mean, both, I think, at the basic and at the clinical level. And we have 5 different clinics in our school. We have the Department of Oral Surgery and Stomatology. We have the Department of Periodontology, Reconstructive Dentistry and Gerodontology, Orthodontics and Dentofacial Orthopedics, and Conservative, Preventive, and Pediatric Dentistry. And I belong to the Department of Orthodontics and Dentofacial Orthopedics. And aside this 5 department, we have opened in the last 4 years, we moved to the building next to the ZMK. These are the building that I highlighted in blue. That is also the building where you see me now. This is Sitem Insel. This is called the Swiss Institute for Translational and Entrepreneurial Medicine. And here we have established the Dental Research Center. So here we perform research in our center only related to dentistry and to craniofacial malformation. And also here we have different type of laboratories. We have the lab for oral molecular biology, that is the lab where I belong to. And then we have other labs, one for oral cell biology, oral microbiology, oral histology, cariology, and erosive dentistry.
Excuse me, Ludovica, excuse me, just a minute. Are you presenting your
Yeah.
Because we are not seeing your presentation. I don't know if you are already sharing.
Yes, I was in. Okay, wait, sorry. Do you see it now?
It's coming.
Okay, sorry. So, okay, I'm sorry.
Yeah,
that
because we forgot to do this step. I thought you would begin just talking,
Yeah,
and then
sorry. No,
I
no.
realized you were showing some
Okay, so,
features of it. Okay, but
Yeah.
don't worry. Now we have your presentation on.
Okay, so
Okay?
I go quickly till where I was. Sorry, sorry.
Okay, and don't worry.
So yeah, so here I put some nice picture about the place where I was born. Okay, this was Trento and Parma, and again Ribeirão, Philadelphia, and Bern. And so I was explaining about our school. So this is the view from the dental school in Bern, from ZMK. Yellow is our building, and blue, okay. And then we have in blue here the new Sitem building institute that I was explaining you what we do here. And I was telling you that I belong to the laboratory for oral molecular biology here. And here also close to the ZMK, so to the dental school, you can see in red, this is a part of the children's hospital. And this is also needs a regard from my side, because we have a collaboration for the project that I'm following with the hospital. So this for letting you know that we are all very close and connected each other, and this is very good for us in order to perform good research, because we have communication with all these institutes. So this is my lab, the Laboratory for Oral Molecular Biology. We are a small team for the moment. So in the first row, you see the team at the moment. So Martin Degen is the PI of the research group. He's my boss. Then it's me. Then we have a PhD student, Farah Mansour. She started 6 months ago. She's a chemistry. And then we have a lab technician, Silvia Rees. And this is, the main team, the team that is working 5 days at FI here. And then we have some other students. We have Annick, that is a collaborator. She's already a dentist. She's approaching the program in orthodontics now, and she's helping us. She's interested in research, and she's helping us at the moment. And this year we also had 3 master students. They are undergraduate students in dentistry, Noah, Anina, and Emily. And they are also very helpful in all the projects that we run. So basically our focus of the lab is cleft lip. And we have 2 main branches of this topic. So Martin, that is more focused on the basic aspect of CLP, and so all the genetics aspect related to CLP, and my focus that is more related to the translation, to a translational level, to the tissue regeneration in the CLP. Okay, so I will start to give you an overview of what I'm going to tell you today. So I will start a little bit talking about cleft lip and palate, which is the most common craniofacial malformation in the craniofacial area in humans. Then I will explain you what is the treatment protocol for this patient here in Bern. After that, I will explain you why we are right to decide to establish a cell bank starting from material that we get from cleft, lip, and palate individuals. I will tell you about the current strategies that we have for repairing the alveolar bone cleft in these patients. I will discuss a little bit around fibroblasts and mesenchymal stem cells, that this seems to be two different cells, but somehow also connected between them. For then moving on our new approach to use this type of cells for reconstructing the alveolar bone, explaining you why we think that our strategy is a good strategy, and then I will give you a little bit of summary, and of course we will have a session for discussion and questions. So let's start with the cleft lip and palate. So let's start, I would like to start and to make it simple a little bit, the craniofacial development. So the craniofacial development is probably the most complicated and intricate mechanism of development in the human body. How it takes place? So basically, it takes place starting from the neural plate border, and from the neural plate border, where there is the invagination of the neural plate border for the formation of the neural tube, there is a population of cells that is detached for the neural tube that start to migrate. And these cells are called the neural crest cells. And these cells are the cells that are responsible for the formation of all the craniofacial structure. Here in the panel A and B on the right side, you can see that starting from the embryo, there are the migrating neural crest cells. And on the panel B, you can see these migrating stem cells, what they are going to form at the end, I mean, when the craniofacial morphogenesis has ended. So, okay, the phase development is, as I say, probably the most complicated and intricate process in our body from a developmental point of view. And it starts around the 5th week. So basically, it starts around the 5th week. And the first thing that is formed when you have the craniofacial morphogenesis, we start from the formation of 5 different facial prominences. The frontonasal prominence, that is the pink one that you see in week 5, 2 maxillary prominences that are outside in yellow, and 2 mandibular prominences. So while the time passes between week 5 and week 6, there is a formation of the nasal pit and the division basically of the frontonasal prominence into 2 medial and 2 lateral nasal processes. At this point, we have the medial nasal processes that they are fusing together with the maxillary prominences that are already formed after week 5 to go to complete the craniofacial morphogenesis and forming the upper lip. And during this stage, this is what you see from outside, so the face development. But during this stage, from week 5 till week 10, is also the time where the palate, the secondary palate, is formed and developed. So the secondary palate starts around the week 5 as well in humans, and start with the vertical outgrowth. So basically, the secondary palate arises as pair outgrowth, which grow vertically flanking the tongue. So here you can see histology from a mouse embryo. So this is the tongue. You have the palate shaft that they are growing vertically to the tongue. Then after 6 weeks, these 2 palatal shafts that have been growing vertically close to the tongue, they elevate. And once they elevate, they start to grow once together each other until they touch each other. And at this point, they can touch each other, they adhere, they fuse, and they form the secondary palate. And this is a very critical point in the palate development. And this is usually the moment in which, if something is going wrong, we can have the phenotype that we call cleft lip and palate. So cleft lip and palate is the most common congenital malformation in the craniofacial area. Indeed, it affects 1 every 750 newborns. That is a pretty high number. And this is not only depending it's depending on the geographical area. So there are areas in the world that are more affected from this kind of malformation. However, the etiology behind this malformation is still not completely known. I mean, we know that there are some genetic causes. We know some genes that are involved in the formation of the cleft lip and palate, but we also know that there are environmental factors that are not completely understood yet, but that we hypothesize that might be connected to, for example, to the behavior of the mother during the pregnancy, like the consumption of alcohol, the consumption of cigarette smoking, and so on. And also the form of the cleft that we see that every year we face here in Berna, but also, wherever, we can have syndromic or non-syndromic form of CLP. And in the syndromic form, that are the minority of all the CLP form, we have cleft lip that appear as a secondary feature in this patient. So this patient, they have other type of problems, and then cleft lip is an associate phenotype with these syndromes that they have. While in the non-syndromic, the patient, they just experience the cleft lip. They don't have any other type of problem in any other site in the body. And also, even if this kind of malformation is not a disabling is not a malformation that is affecting the life of this patient, is of course a huge disabling malformation. And this is a disabling malformation not only for the patient, but also for the family, that they have to face this kind of malformation when the kid is born, and that they have to learn how to deal with this malformation. Okay, so now I will introduce you how we treat this patient in Berna. So as I was telling you, this is a really disabling malformation, and the assistant of this patient is an assistant that is lifelong. So basically, it starts with the diagnosis, even if the patient are not yet born, because at the moment of the diagnosis, there is a huge burden for the parents of the kids. Because of course, even if this is not a severe malformation that is compromising the life of the patient, their acceptance is still difficult. So from this moment, the parents of the kids, they are already assisted from psychologists in order to accept this malformation. And this, of course, is something that became also very important at the moment of the birth. Then when this patient, they are 3 to 5 months, usually what is happening in Berna, because the treatment plan, it's different from center to center. This is, I'm telling you about the surgical protocol that we follow in Berna. So when the patient are 3 to 5 months, there is the lip correction. So the lip is closed, and this is closed usually to help the feeding of the patient. Then the palate correction occur when this patient, they are around 12 months. And then there is a huge gap until this patient, they are between 7 and 12 years, when usually it occurs the reparation of the alveolar bone, if the alveolar bone is also affected from this malformation. After that, there is a long time for the orthodontic treatment in order to allow proper dentition in this patient. And then usually when this patient, they are adults, so when they are usually between 18 and 20 years old, there are several other surgeries that usually they are aesthetical surgeries to improve also the aesthetics of this patient. And of course, all this treatment protocol is followed by a series of specialists. So first of all, we have the psychologist, and the psychological support for this patient, it occurs immediately. From the moment of the diagnosis, to support the parents, but also for the patient and for the parents itself along the life of the patient, for letting the patient accept themselves and getting also integrating social. I mean, this is a very important point that is not always considered because we always think to the surgical treatment, but this is something that is really disabling and really a burden for this patient. Then the second moment is the surgical team, basically. And the surgical team, I mean, starts at 3 to 5 months with a lip correction, and this arrive until when this patient, they are adults. And here I involve, of course, pediatric surgeons, but also maxillofacial and plastic surgeons. And then another moment that is very important when these kids are around 12 months, or when we had the palate correction, we need the intervent until these patients are almost adult, or speech therapists to help them in improving their speech capabilities, their speaking properties, and so on. And then the last group of specialists that we need in the treatment of the patient is the group of the orthodontist, because after that the alveolar bone cleft is repaired. Of course, we need the orthodontic treatment to improve and fix the dentition of this type of patient. So as you can see, this is a really complicated and long treatment protocol that causes a huge burden for this patient. And the idea would be to try to solve and to reduce the burden of this patient for this type of protocol. Okay. So what was our idea? So as I show you in our surgical protocol, when this patient, they are 3 to 5 months, they undergo to the lip closing surgery. So the lip closing surgery is performed to fix the cleft lip and to allow the patient, allow the feeding of the patient. And during this cleft surgery, here you see the timing of the surgery. So we have the cleft, then we have the planification of the surgery and the suture of the cleft lip. We have an excessive piece of lip tissue that this is usually discarded from the surgeon. So this is not necessary for diagnostic purposes. So usually it's going to be trashed. And we decide basically to save this tissue and to start to isolate cells from this tissue. So we transfer this tissue to the laboratory. We cut this tissue in small pieces. We put in culture, and through the explant culture technique, we allow the cells to grow out, to outgrow from this tissue. And after a couple of days, we can already see that there are some evidence of cells that are starting to grow out from these tissues. And after 4, 5, 6 days, you see that this cell population is growing. And we observe that 2 types of different cells can outgrow from these pieces. We have some cells that have a spindle-like shape morphology. These are mesenchymal cells, mesenchymal outgrowth. And then we have more cobblestone-like cells, and these are epithelial cells. And we, of course, characterize this cell. So we have the epithelial cells that are, as I was saying, they are cobblestone, they grow in colonies, they are positive for ecadherin, as you can see in the first line. And then we have the mesenchymal outgrowth that they consist of cells that are more spindle-like, they are elongated, these are probably mostly fibroblasts. We characterize them as fibroblasts. And these are vice versa, negative for the ecadherin, but they are positive for vimentin. So we can establish and isolate these cells in a reproducible way from all this lip tissue that we have. So we decide to collect all these cells and we decide to start to biobank them. So basically what it happens when we have a tissue biopsy that usually, if it's not for diagnostic, go to the medical waste, we transport this biopsy to the research lab. And usually we give priority to the cell isolation, as I was telling. But we also save some piece of the biopsy when we can for tissue histology or for freezing direct with the tissue that can help us for research in the future. And starting from the CLP, we now collect a lot of CLP tissue biopsy, but then we increase also our collaboration with the children hospital that is giving us the biopsy. So we have also a series of other type of biopsies that we collect in our cell biobank and that are helping us for our research purposes. So we have also biopsy isolated from healthy lip and from other sites. And these usually we get when we have access, the same surgeon that are surgerying the CLP patient, they also have access to the emergency. So sometimes some kids, they arrive with the emergency, they had to cut excessive tissue and they provide us this. In addition to that, since we are, of course, affiliated to the dental school, we also get from the Department of Periodontology other type of tissue, like, for example, gingival dental pulp and periodontal ligament tissue. Okay, so why we think that this model, I mean, they are good models. I mean, I will just provide you a quick example, for example. And for example, is we have these cells, and these cells, they may be very good models for studying, for example, rare diseases. In this case, for example, we are in our lab also interested in this kind of syndrome. This is the van der Waals syndrome. That is a very rare syndrome that it occurs 1 every 35,000 till 100,000 of newborns. So it's a very rare syndrome that among the other clinical phenotype, they have also the cleft. So in these 64 biopsies that we have collected also a biopsy from a CLP patient and also one from an adult patient. And basically what we did, I mean, just for giving you an example, we get the tissue biopsy. We did some histology with this tissue biopsy that we had. We isolate the cells, but the very interesting thing is that, for example, in the keratinocytes, we were able to see that these cells, they maintain the genetic mutation that they have in the patient. So basically, this syndrome, the van der Waals syndrome, is caused by an haploinsufficiency, usually of the interferon regulatory factor 6. So this patient, they usually have an haploinsufficiency for this gene, and we have been able to observe that in the keratinocytes that we isolate from the lower lip and from the gingiva of this type of patient, we still have an haploinsufficiency of the IR6. So basically, this is a good model because this allowed us to use these cells that they already have a mutation inside to study this disease and to better understanding the mechanism and the pathology of this disease. So this was an example how we can use our cell bank. And on the other side, when I joined the lab, I start to think together with my boss. Okay, this is true basically for the keratinocytes, but can we try to make a good use also of the mesenchymal cells somehow? And here it came our idea, so the main topic, the main focus of my lecture today. So going back to our CLP patient, I mean, when the CLP patient, they born with a cleft lip, when is involved also the palate, usually this patient, they also experience a bone cleft. So basically there is an interruption of the maxillary arch. And this is one of the most probably common manifestation associated with the CLP. And here you can see some clinical pictures. So you have basically really the interruption. So it means really a piece of bone. And this needs, of course, to be repaired for several reasons. First of all, because we need to allow the proper descent of the permanent teeth into the maxilla. And if we have the interrupted bone, this is going to be difficult. But this is also important to facilitate the oral hygiene of this patient, still to improve even more the speech and hearing capacity, to improve, of course, their food intake, because also this is a problem. And last but not least, also for aesthetical reasons. And nowadays, the autologous bone graft is the gold standard for the treatment of this type of defect. And this is the gold standard also for the treatment of craniofacial defect in general in the craniofacial area. And usually the autologous bone is kept from the chin, from the ribs, or from the iliac crest bone of this patient. And why we use this type of bone graft? Because basically it's nowadays the only available material that is possessing at the same time osteoinductivity. So it means that it contains the molecules that can stimulate the new osteogenesis. Is the only material that is also providing a scaffolding material because it's bone. So you have a scaffold where the cells can grow in. And also osteogenicity, because in this being autologous bone, you have also the cells of the patient that they have already the capacity to depose new bone. But beside that, we also have, of course, some drawbacks that we cannot avoid to think about. So the drawbacks are, first of all, we have an unpredictable resorption rate for the autologous bone graft. And this, in CLP patient, it has been described in between 10 and 36% of all the cases where we have used autologous bone for the reconstruction of the alveolar bone. But of course, we have also morbidity of the second surgical site, because it's another invasive surgery, because we are going to take the bone from another site. And this, I mean, this is a huge burden and a further surgery that is required in this type of patient that, as I show you, they already have a very intensive treatment protocol. So we wanted to find a solution, something to reduce the burden of the patient, to say, okay, let's try at least to avoid this further burden, this further surgery in this patient. And so, since we have available this cell bank, we started to think, okay, what about cell therapy? Why not using a cell therapy approach? So cell therapy, it seems something really utopistic, but in the end, it's something that is already really used in the clinical practice. So the cell therapy, it means to get some viable cells that need to be injected, grafted, or implanted into the patient for any type of medical reason. And this is something that in the clinic is already used since a long time and is used, for example, in the autologous hematopoietic stem cell transplantation. This is a type of stem cell transplantation that is performed in, for example, in persons that are affected from leukemia. So basically what it happens is that we have a tissue collection, so we mobilitate and collect the hematopoietic stem cells of the patient into the peripheral blood. We collect the blood, we extract afterwards the cells from the blood, and we thaw them until they are used. Then the patient can undergo to the chemotherapy to suppress completely the immune system, and then these cells, they can be reinfused in the patient that can replace completely the immune system. And if you think this kind of approach, we could follow also for other type of defect, like in the case, for example, of bone defects. So ideally, we could think to get the autologous tissue rich in, for example, in bone cells from the patient, then to extract these cells, to freeze these cells, to prepare the patient for receiving these cells, and then to reimplant these cells in the patient. So this is a little bit the strategy that we would like to follow for a cell therapy. So we went to the literature and we start to try to think which kind of cells can be used for a cell therapy approach. And we found out that there are actually a lot of clinical protocols that are going on for the regeneration of defect in the craniofacial area, including the cleft, with different type of cell sources. We can use minimally manipulated whole tissue fraction, like can be a bone marrow aspirate, and then using this tissue fraction reimplanted in the patient together with a scaffold. The use of minimally manipulated whole tissue fraction is of course good because it offers the feasibility also of a chair-set protocol, and there is a minimal manipulation of the cells that then are going to be reimplanted. And also it's a good method because we can provide to the patient a heterogeneous cell population, so that with all the factors that should help already the bone regeneration. But otherwise, we can also use only cells. We can use in vitro expanded uncommitted cells, like it can be the mesenchymal stem cells that we can isolate from the bone marrow. Or we can also use in vitro expanded but committed cells. So basically cells that they are already committed, they are already epigenetic committed to be differentiated into bone-forming cells that can be, for example, osteoblasts or periosteal cells that are isolated from mature bone. And not long time ago, so a couple of years ago, it has been released a systematic review with a meta-analysis where it has been investigated basically what is the effect of using a cell therapy for orofacial bone regeneration. And among the other defects, 7 of the studies that have been considering in this systematic review were studies that were considering the regeneration of the unilateral or bilateral alveolar cleft. And so 3 of these studies, they use the bone marrow aspirates. So basically the minimally manipulated tissue fraction. And what they did was basically to combine this bone marrow aspirate together with a biomaterial and comparing the efficacy of these implants to the gold standard. So basically to the implantation of the Lia-Crest autologous bone graft in this type of patient. Then 3 other studies, they used uncommitted stem cells, so mesenchymal stem cells, that were isolated both from the adipose or from the bone marrow tissue. And 1 study also used the osteoblasts, so committed, expanded but committed cells. And after the meta-analysis, the results revealed that the use of these cells in combination with the material itself, it basically had an effect that was comparable to the autogenous bone in terms of bone regeneration. So this is for telling you, okay, the use of cell therapy for the reparation of this type of defect, it may be an option. We have an option. We know that this option could work for regeneration as good as the autogenous bone. So what should we do? Should we proceed to follow such a way? And so this is why basically we started to study our fibroblasts. So the fibroblasts that we isolate from the cleft lip. And we started basically trying to characterize these cells because there is a huge confusion in the literature at the moment that is telling us what are exactly the mesenchymal stem cells, what are exactly the fibroblasts. So we started studying what are the mesenchymal stem cells. So mesenchymal stem cells, they are multipotent cells that are important in the physiology for repairing the skeletal tissues such as the bone, the cartilage, and the fat that we can find in the bone marrow. They have been firstly described in the bone marrow by Friedstein in 1966 as a small population in the non-hematopoietic cells of bone marrow, with rapid adherence and fibroblast-like morphology. And these cells, they observed that they were able to differentiate in other type of cells. So this is why they call them mesenchymal stem cells. And with the year, these type of cells, they have been described and isolated from a lot of other tissue, including the adipose tissue, the dental pulp, and all the fetal associated tissue like placenta, umbilical cord, Wharton's jelly, and so on. And over this tissue, that these are the canonical where we can find the mesenchymal stem cell, there are a lot of tissue and we have a lot of literature of authors describing mesenchymal stem cells more or less in every tissue. So this is the reason for why at some point the International Society for Cell and Gene Therapy had the necessity, let's say, to define some criteria for defining mesenchymal stem cell and say, okay, this is really a mesenchymal stem cell. And these 3 main conditions are, the first thing, these cells should be plastic adherent cells. So cells that if you put in culture, they grow on the plastic. The second thing, these cells, they should express, at least in 95% of the population, 3 different clusters of differentiation, the CD73, the CD90, and the CD105. And the third criteria that is also the most important, these cells, they should be able in vitro, when treated in the opportune way, to differentiate into bone, fat, and cartilage forming cells. Okay, and now what about the fibroblasts? So we have this statement from the ICT, and now what about fibroblasts? I mean, fibroblasts, we all know that these are the cells that are involved in the production of the extracellular matrix in all the tissue. That they are involved in wound healing and in the maintenance of tissue homeostasis. But already in 2008, Lawrence et al. They show that fibroblasts, they exactly have the same properties that have been described for the mesenchymal stem cells. And from this moment, it starts a huge discussion among the scientific society about what is a fibroblast and what is a mesenchymal stem cell. And many papers have been published in the last 15 years regarding this topic. What are fibroblasts? What are mesenchymal stem cells? Are they the same cells? Are they siblings? Are they brothers? There are some differences in between them. And this is basically the reason for why we pushed ourselves to think to use the fibroblasts that we isolate from the lip tissue of this patient for the reconstruction also of the alveolar bone in this patient. So this was our focus. Could we imagine to use our CLP lip-derived fibroblast for alveolar cleft repair? Okay. So the first thing that we did was to test the multipotency of our CLP lip-derived fibroblasts. So we take these cells in culture, and the first thing that we wanted to do was to compare their shape, their morphology, to the morphology of mesenchymal stem cells that we isolate from the bone marrow, and that here you see labeled in black, and to WE38. WE38, they are a commercial available cell line of fibroblasts. Fibroblasts isolated from lung, but fibroblasts. And as you can see here, I mean, all these three types of cells, they are plastic adherent. There is a similar morphology, more close between the CLP and the mesenchymal stem cells, with cells that they express focal adhesions, so they are positive for vinculin because they are attaching on the plastic. And then after that, we faxed these cells, and we went for the investigation of the expression of the surface marker. And we saw that in all these three populations, including the WE38, including our CLP fibroblasts, more than 95% of the population was positive for CD73, CD19, CD105. And then again, we tried the differentiation. And we tried to induce osteogenesis, adipogenesis, and chondrogenesis in all these three types of cells. And we observed that while the mesenchymal stem cells, as expected, they were differentiating into bone, fat, and cartilage-forming cells, the WE38 that are real fibroblasts, they are cell-like fibroblasts, they were not able to differentiate. Vice versa, our CLP fibroblasts in vitro, they were able to differentiate into bone, into fat, and into cartilage-forming cells. And this, of course, for us was a wow, a boom results, because this we say, okay, if we really have these cells that they have this potential, imagine how we can reimplant these cells into the patient. And we also assess another characteristic that is not a main characteristic described for the mesenchymal stem cells, but that is usually typical of mesenchymal stem cells, that is the capacity of this cell to grow in colonies. So you can see these cells at a very low density, and whether these cells, they have a high proliferative ability, like the mesenchymal stem cells, they can start to grow and to form colonies. And after 14 days, you can see that while for the mesenchymal stem cell, for say CLP, we have some nice colonies that have been formed on the tissue culture plate, the WE38, they completely missed this capacity. So we observe this, we say, okay, we have our fibroblasts that they have some capacity that reflect the one of the mesenchymal stem cells, but they are also different from WE38, and WE38, they are defined as fibroblasts. So we ask ourselves, it's not that in our maybe CLP fibroblast population, we have some mesenchymal stem cells that are hiding. And for trying to understand this situation, we perform a single cell clonal analysis. So basically, we have our culture of fibroblasts that they are growing in colonies. And then what you can see is to expand single cell populations starting from each one of these cells. So basically, you have cell populations that are derived from a single cell, so that they should be homogeneous population of cells. And for all these cells, we try to differentiate them into bone-forming cells and to assess their capacity to form colonies. And surprisingly, we obtain around 100 clones for each type of CLP that we analyzed. But we observed that while some clones were still able to form bone, even if not in a superior way if compared to the parental population, there were some clones that they were not able at all to form the bone anymore. And this let us question, okay, now we have these type of cells that they still form colonies, they don't form bone, but we have others that they form bone and they don't form colonies. So what are really these cells? So this the reason for why we try to characterize the marker, a marker that should be expressed only in fibroblasts in our cells. And we found out that our clones that were able to form again bone or not able to form bone, they were all still expressing the fibroblast specific protein. While compared to the mesenchymal stem cells, our mesenchymal stem cells, they are completely devoid of the expression of this marker. And the interesting thing is that this marker in all the clones, also the ones that are able to form bone, is expressed up to 99% of the population. So basically, these are fibroblasts. So we were able to show that this capacity to form the bone is coming from the fibroblasts. So we have fibroblasts that we can really potentially use for the reconstruction of the alveolar bone. So now that we have seen this fibroblasts, what would be the advantages of using this fibroblasts for the reconstruction of the alveolar bone or for any type of tissue regeneration in this type of patient. First of all, the donor age. And so usually when we isolate the mesenchymal stem cells, we would need to isolate mesenchymal stem cells from patients that are usually between 7 and 12 years old. So in the moment when they have the surgery. And we know that the age is affecting also in mesenchymal stem cell the capacity to differentiate. While for the CLP fibroblasts, we are isolating these cells when these patients are really young, when they are 3 to 5 months old. And this may be a reason for the potency of these cells on one side, but also it may help to keep longer also in culture the multipotency of these cells. The second advantage is the amount of the cells. So the mesenchymal stem cells, even if we isolate them from the bone marrow, they are usually very rare cells. So you found 1 mesenchymal stem cell to 10 to the 6 cells. While the fibroblasts, we know that are the most abundant cells in the lip tissue, but in any type of skin tissue. And this would avoid basically to excessively expand the cells. So it means that for the mesenchymal stem cells, you should treat them for a long time in culture in order to reach the critical mass of cells that you would need to reimplant in the patient. And this would lead to the risk to introducing, of course, genetic instability and mutation in these cells. And this is something that with the fibroblasts we could avoid. Similar to the amount, also the heterogeneity. So the mesenchymal stem cells, again, they are rare, and you have to select exactly that cell. But the fibroblasts, we have seen that they are a heterogeneous population. And this means that we would already have the critical mass that we need for implantation. And in this heterogeneous population, since we have a critical mass, also the cells that we have seen from the clonal analysis, they cannot form further bone. These cells, they can be useful anyhow because they would provide mass to the whole cell therapy. Then again, the embryonic origin. This is also something very important because the mesenchymal stem cells we usually isolate from the bone marrow from the iliac crest. So the iliac crest has a mesodermal origin, while the CLP fibroblasts, being cells that are isolated from the craniofacial area, they have a neural crest origin. And the embryonic origin of this cell would fit the embryonic origin of the alveolar bone that, being a craniofacial structure, is also derived from the neural crest. And last, the tissue source. Mesenchymal stem cells, as we said, we need to isolate from the bone marrow, and we would require a further surgery in this type of patient, while we are isolating our cells from discarded lip tissue biopsy. This is something that is really, in my opinion, priceless. This would, of course, cause no extra harm for the patient, but also no extra consultation time for the parents that they are already subject to a psychological burden for this kind of malformation. So to summarize everything, to conclude and to report to you what would be our strategy. So we would have, at the time of the lip closing surgery, we have the cleft lip that is surgically correct, and we excise this excessive lip tissue. Then this tissue, when the patient is 3 to 5 months, then this tissue can be transferred to the lab. In the lab, we can extract the cells, and we can characterize and freeze the cells until the cells are needed. Then our idea is to thaw these cells when they are needed before the alveolar cleft repair, to expand the cells, to combine the cells with a biomaterial, preparing a biological substitute that then, during the cleft repair, we can bring and implant into the patient. Okay, so I'm basically at the end of my talk. I hope I was not too long, not too short. I would like to leave you these 2 references. These are the 2 papers that basically I tried to explain you today. And I would like, of course, the acknowledgements. I mean, first of all, my team. So the whole molecular biology lab, Professor Katsaros, that is my big boss. That is, of course, not only the first supporter, but is also the first economical support of our lab. Martin, my PI, Farah, Anik, and Silvia, because they are always very supportive also on this side. And then Eleftheria, that is our former PhD student. She left the lab 1 year ago so far, and Julia was our former technician. She also provided us great support through all the project. And then also all our collaborators. with Giorgio La Scala and Isabel Schneider, they are the clinical collaborators. They are the pediatrician that they follow the surgery of this patient. Professor Sculian, Dr. Ostelli, and Dr. Rocuzzo, they are our provider of tissue biopsy from the dental school. And also Professor Dieter Bosser, that is always supporting us when we need any type of support from his side with histology. Then I would like to thank the Osteology Foundation, that is the main supporter of this project. This has been fully supported by them so far. Of course, CITEM and ZMK for helping us and for providing us all the structure that we need in any time. And the young CADR that is also supporting me anytime that I have to give a lecture and so on. And finally, I would, of course, like to thank you all for the attention. And this is my contact. So if you have any question, any curiosity, any willing to come to Bern and to visit us and to see this amazing panorama, so this is exactly what you can see from our lab, you are more welcome to get in touch with me.
Great, Ludovica. Thank you very much for your excellent work and excellent presentation. Very, very interesting what you are doing and how you are trying to make it simple, or trying to, with all the technology you have, all the things you know, bringing back to fibroblasts, bringing back our knowledge, all this knowledge to a more, I would say, feasible way of treating this kind of problem. So at this point, I would like to ask if Dr. Paulo would have any questions for you. I believe he has. So please, Dr. Paulo, if your dog allowed, if your neighbor dog is allowed, please. Dr. Paulo is saying no questions. I believe the dog is still barking there, and he's saying that it was a fantastic presentation. So I'll ask now, Pedro, please, do we have any questions from the audience? And Paulo is also saying that we have an outstanding collaborators also. So, yeah.
Thank you a lot, Professor Paulo.
We don't have yet
any questions. Okay,
yeah.
Benedetta, we have any questions from you from Parma?
Just a curiosity. You say that you want to use the cells on biomaterials to try to regenerate the lip and the palatal cleft. So which kind of biomaterials are you working on, and what are you planning to use in the future?
This is a good question. I mean, we are now approaching the preclinical testing of these cells, and we are testing different kind of biomaterial in vitro. We are testing the proteinized bovine bone mineral, but we are not really convinced of using this type of material because this is a material that is not then resorbed. So it may be difficult to allow the descendant of the teeth without having side effects like root resorption during the orthodontic treatment. And we are also trying with some collagen matrices. So probably, and hydrogels, yes, is another good point. We are also testing a hyaluronic-based gel. So we are trying to find the right material. So this is something that we are testing now in vitro, but that, I mean, I hope within 6 months we can start already with animals and already to have the right material to implant. But what I would like, to be honest, is a material that is not really, I mean, at least for the preclinical testing, I would like to have a material that is not such a good material for bone regeneration, because I would really like to show that are the cells that are able to form the bone, because this, I think, is something, and very important. I would like to have also something that is completely resorbable for that. So probably a collagen matrix or an hydrogel would be the best option.
Thank you very much. It was an amazing presentation.
Thank you.
Thank you, Benedetta. Benedetta is also part of our collaboration. She is still in Parma. She has been outside Parma for some months, right, Benedetta? But now she's back there,
Yes.
and we are finishing some manuscripts and so on. So to go on with this collaboration. So very important point, I believe, this whole consideration about scaffolds and what would be the real therapy, as Professor Paulo just point out, because we have to understand which would affect more, the cell therapy or the scaffold preparation or material source and so on, right?
Mm-hmm.
So it's very interesting to see your point. I believe it's really incredible how you're doing the things and how from the simple things you can generate a very comprehensive situation.
Yeah. I would
so
like
go
to
ahead.
say, I would like also to say one thing. I had a discussion on the topic lately with Professor Bossart, and he asked me about how I see feasible this in patients that I are not cleft patient. I mean, this is something that I have to be honest on, that I see feasible for cleft patients, because these are patients that they, as I said, we would like to reduce the burden for this type of patient. But this is something that in Europe is studied. At the moment is financed by an ERC grant, and is the largest clinical study in Europe for the regeneration of small defects before implant placement. So on a clinical level in dentistry, I'm honest, I don't see this as a good application. And I don't see this as a good application because I think that the cost for the patients, and also, basically the cost of the patient, but also the benefit for the patient in a dental level would not be enough to go for such type of therapy. But I think that for our purposes, this is something that would be for sure ambitious if we can arrive on the clinic with such an approach. But we have the support, and I think this is something that we can pursue. But it's important to state that, at least in my opinion, this is not something that is feasible, and we had to consider it for other type of application. Because it would be, of course, amazing also in other type of application, but it's really worth and useful for the patient to get a bone marrow aspirates, for example, for regenerating the maxilla for an implant placement, when you can easily use the proteinized bovine bone mineral or other type of material. So these are, I think that this is very borderline, but that this kind of therapy we have also to consider for the aim, and so for our final goal, and considering everything, not only our wish to create something nice, something good, something outstanding, but also always considering also the clinical benefit for the patient itself.
Yes, but keep in mind that I understand that this cost, this risk benefit, and so on, it has to be the main purpose of your work and so on. But as you go in the research with the materials and so on, and you might probably at the end get some from that. So you may be at the end knowing that the cell homing in dental defects, in periodontal defects would be the better approach, but also you are searching and improving in the scaffold. So, it's just like a way to go in all the senses. So, I don't know if we have any questions more for that, for the lecture.
Yeah, I have one. I would like to know if you think that if you choose a different fibroblast for another place, it could express a different phenotype that it could change our results.
Yeah, this is also a very good question, especially from the biological point of view. So as I mentioned, we believe these fibroblasts, they have this huge capacity because they are derived from the neural crest. But, and we are testing other type of fibroblasts from the neural crest, like gingival fibroblasts, periodontal fibroblasts, dental pulp fibroblasts, palate fibroblasts. And all these cells, even if they are isolated from older patients, they seem to have the capacity. When we use other type of fibroblasts, like we have access, for example, to foreskin fibroblasts, these they also have the capacity, but is way reduced if compared to the one in the craniofacial area. So we really believe that this is something that's, that is really special for the craniofacial area. So I'm not saying that in absolute other type of fibroblasts, they don't have this capacity. For sure they have this capacity, because also in the time we have observed that the fibroblasts, they are just the stage after the mesenchymal stem cells. So in the process of aging, the mesenchymal stem cells, they anyhow transdifferentiate into fibroblasts. But the fact that they are so multipotent, I believe, and we strongly believe in that, and we are trying also to study this on the wet lab, is because of the embryonic origin of the cells. So it's really the neural crest that somehow they trigger probably something related to the epigenetic of the cells, so the methylation of the cells. But we had the feeling that these cells, they remind in their genome that they derive from the neural crest, and this give them this multipotency.
So do you think that you just
go ahead, Pedro. Sorry.
So do you think that you can change this gene to express the same phenotype in the cells? Like you can edit these genes and you can make it express like multipotent cells? Yes,
this is for sure something that is feasible, but I would like to make a joke with you. As me and Fede teach you with pizza, as less is better. I think that if you have the possibility to use a cells that you don't have to excessive manipulate, is always better. So for sure, you had the possibility with the biotechnology to take fibroblasts from the foreskin of a 7-8 years old patient and to genetically reprogram it to go back to an undifferentiated cells, and thus providing multipotency. But this is something that you have to consider. Is also an excessive, in my opinion, manipulation of the cells before their implantation. You don't know with this kind of manipulation which other type of genetic pathway you can activate that then they can cause other type of problem. This is also something to consider related to the use of mesenchymal stem cells. I mean, the huge problem at the moment with the mesenchymal stem cells in the clinic is that we don't yet have a proper safety report about these cells. So we don't know whether we implant today these cells in 10 years, they may cause any type of other problems like related to cancer or whatever. While the fibroblasts, this is also very important for our fibroblasts, but this also for fibroblasts from other side. These are cells that the stage of the totipotency of they already step away. So also from a safe point of view, our cells, they may have also this advantage. And these advantage if compared to other type of cells. These, of course, are all things that we have to study, that we still under discussion, but that, I mean, it's also, they are also worth of mention.
Thanks so much.
You're welcome.
Thank you, Pedro. Just one question, just speculating about the research that you might know about there and so on. From the epigenetic point of view, you said in the beginning of your presentation that you, of course, in this, and we know that in this kind of problem, in the palatal cleft, in the lip cleft, there is a huge possibility of epigenetic disorders, right? Mm-hmm. Right from the beginning of the life. Is there any path that you are seeing, and these are making you think in this direction? You know, because you are.
That is causing problem, you mean, in this direction?
I mean, that knowing about these epigenetic features and disorders at this point, at the beginning of the life, leading you through this research at this moment. I mean, if you could understand any drug that you could interfere in the patient before receiving the cells, for example.
Okay, yeah, I got your point. Well, we don't have, I mean, this is of course something that has to be considered, because these patients, anyhow, even if they have a non-syndromic form of cleft, they anyhow, I mean, something that is wrong in their genetic background. And we have, first of all, first thing, we used for this study always non-syndromic cleft lip sample. So we don't know the genetic background of this patient. But on the other side, we have, as I mentioned, some samples that we isolate from van der Waals patients. So we have the genetic background because we did the sequencing of this patient, and we know that this patient they harbor mutation in IR6. And IR6, we were worried about that because it's a gene that anyhow is mutated, and maybe can cause some also impairing, the capacity of these cells to differentiate and so on. But we have seen that this is a gene, for example, that is expressed in the keratinocytes, but is not expressed in the fibroblasts. So we have a problem for this, in this type of patient, that they form the cleft because they cannot properly form a periderm, and then when you have the palate shelf elevation, the palate is not fused properly. But this is a genetic defect that is affecting only the keratinocyte. So the fibroblasts, they don't express this gene at all, and this let us believe that even if they don't express the gene, this should not affect their multipotency. And indeed, now with these patients, since we have a young and a old patient, we are doing the same type of experiment with two, the patient at 3 to 5 months and the patient 19 years old, because they are both affected from the same syndrome. And we have evidence that the young one, anyhow, is still able to differentiate, while the old donor is losing this capacity. So this is something that for us is letting us believe, okay, even if they have this genetic mutation, we are on the safe side, because it's affecting a cells that anyhow we are not going to use. But for sure, I believe that this is something that needs to be elucidated in the future. And not only the genetic background of this patient, but also the type of cleft that they have when they burn. Because this, I think, is something that is also affecting whether it's a severe cleft, like a bilateral complete or an incomplete unilateral. This is also something that I think is worth to study and to observe whether the different type of cleft that they affect at least the capacity of these cells to differentiate.
Okay, so do we have any more questions? No, Pedro?
No. Okay, amazing talk.
Okay. So I believe with this, we can end our presentation, finish the things. And I would like to thank you, Ludovica, for being here with us today with this wonderful lecture and showing this magnificent piece of work that you are doing there and in the lab that is receiving you and that is having you there. And I would like to acknowledge you all how much you have grown at this time, at this point, and the level of research you are bringing and presenting. So I thank you so much for accepting this invitation, and that many more could happen, that more could come. Okay.
I would like to thank you a lot for inviting. It was really nice also to receive. Professor Paulo was, I think, from when we came to Brazil, we felt that we didn't meet, so it was really nice, and Pedro too. And I really hope that one day I can be back there and meet again in Ribeirão. This would be amazing, really.
For sure, we would like to have you here again, for sure. And also Benedita. We would like to have you here, okay, Benedita, for your first time. So I believe we can end the streaming, right? If nobody has more questions. Okay? So thank you so much. Just let me know when we stop the streaming, okay? Who has to turn